Okay, I think we'll make a start. Kia ora koutou and good evening. Welcome to the New Zealand Healthcare Home Telehealth webinar on telehealth learnings and experience. I've got a fantastic panelist group with me joining me tonight, and I can't wait to introduce them. But before we start, we're going to do a karakia and then we'll move into whakawhanaungatanga. Feel free to join in. Tu taua mai e ronga, tu taua mai e re raro, tu taua mai waho, tu taua mai roto, ki tau ai, ti Māori tū, ti Māori ora, ki tau katoa, haumi e, tai ki e. Kia ora.
Kia ora.
Okay, so I wanted to put the healthcare home model of care up here on the first page, just to show these are the 38 characteristics within the model, and 2 or 3 key components or characteristics of the model include alternatives to in-person consults, which you'll see there, 13.1. I've also included in here, and we'll talk a little bit about it, is the fully functioning portal. And that's because many of our portal vendors have video capacity within their product, as well as in here, the acute demand domain has telephone assessment and treatment. So that's a lot of telephone work for general practices. So it's just a reminder where telehealth is right in the centre of our model of care. So that's what we'll be covering tonight. And we have numerous panellists who will share both their primary care and secondary care experiences in implementing telehealth. And I think of all nights, it's been an interesting day, particularly for our panellists, and they'll share some candid moments of how today went for them as we entered another lockdown. So yeah, I just want to get our panellists to introduce themselves. So Cheryl, are you happy to go first?
Sure, just as an introduction? Or?
Yeah, just as an intro.
Kia ora koutou, ko Cheryl Britton aho, no muri whenua, kia ora rāna.
Kia ora, Cheryl. Angela, do you want to go?
Kia ora, Angela Blunt aho. I'm the Health Services Manager at Kaikoura Health.
Great, thanks Angela. And Janine.
Kia ora koutou, I'm Janine Bycroft. I'm a GP based in Mount Wellington in Auckland, and I'm the Executive Director for Health Navigator Charitable Trust.
Thanks Janine. And Carol.
Kia ora koutou, ko Carol Limber aho. I work at Canterbury DHB and Lakes DHB, led quite a few programs around acute demand, and more recently was a lead for the ministry around acute demand.
Great, thanks Carol. So, and myself, ko Jess White tuku ingoa, ko Aotearoa tuku monga, ko Rumahanga tuku awa, no whakaoriori aho, nō reira tēnā koutou, tēnā koutou, tēnā koutou katoa. So I co-lead the Healthcare Home Collaborative, so really excited to bring this webinar to you tonight. So I am going to hand it over to our first panellist, Cheryl, and look, Cheryl is going to share some of, experiences in the lockdown back in 2020, and then obviously today as they moved into that transition back into lockdown and what it was like for her general practice Te Hiku Huora, which is up north. So Cheryl, I'll pass it over to you and you can tell us what worked well and some of the challenges you had today and you've had previously.
Kia ora anō, thanks Jess. So I am the practice manager of the GP clinics and dental clinic for Te Hiku Huora, which is based in Kaitaia. Our GP clinics service 13,500 patients in Kaitaia and surrounding districts. So that's about roughly 70% of the enrolled population in this area. And we have 2 clinics, one based in Kaitaia and one based at Cooper's Beach. So back in the day, I guess we embarked on the neighbourhood healthcare homes journey about 4 years ago, because things were becoming really tight in terms of capacity, ability to service patients. In the good old days, it was left up to the admin staff to make decisions about priority and what patients were seen on any given day. Because we are not clinically trained, often there was like a yellow schedules all day. So essentially clinicians double and triple booked because we're fearful about who should come and who should not. And that was a really unsafe model, and it was not sustainable in the long term. So, and you couldn't solve that problem by just continuing to put more and more clinical staff on the ground. So it was around looking to see what were some systems that we could introduce that enabled us to be able to better structure the days, keep our clinicians safe, keep our patients safe, and offer a really good service and get to those really challenging areas around primary care, you know, getting to the proactive model and things like that. So neighbourhood healthcare homes, the model offered a number of systems, particularly around having clinicians decide and prioritise who would need to come on the day, and structuring that. It gave them the ability to have some control over their schedules and who was coming, to allow for any pre-work that needed to be done, almost like a meeting before the meeting, so to speak. And so you know, that was a really key element. Also to developing systems around, if we were to look at offering different types of appointments using other modes, what would that look like? How would we structure that as a practice? To be honest, until COVID came along, that was the real big boot to shift into the virtual space. And for us in the far north, that was mostly focused around telehealth, actually. Although there was capacity and the ability to do the virtual consults via Zoom or any other mechanism, the internet stability for our patients, we were fine as a team on site, but for our patients out in the community, the internet was not stable, and it caused a number of frustrations both for the clinician and for the patient, because there was, you know, a lot of dropout during the consultation, time would run over, then you're into the next patient, etc. So most of our kind of virtual space was around telehealth, because we knew we could make the call. There was also some challenges around that with regard to when you had telehealth structured or interspersed with regular patient appointments. As we know, as soon as a patient gets in front of a clinician, they have a trusty scroll of things that they would like to discuss. And so it's kind of easier to manage when there's patient run over if they're in the waiting room, but not so if somebody's sitting waiting for a call at home. So a lot of those system elements, you know, we still continue to work through to balance it and see how it would work. But as I say, COVID was the big push to actually move into the virtual space, which was great because we really hadn't forced ourselves there. There was a massive learning curve in terms of developing guidelines for the clinicians as to looking at overseas experiences and what was safe for them to bring, what was safe for them to effectively manage over the phone. Previously, it had just been triage. Do you come or do you not? And prioritization of appointments. Now it was a shift from that determining priority through to actual management of a patient over the phone. And there was varying comfort levels for clinicians around how they felt about that management process. So we developed some guidelines around that. For some clinicians, they were really happy to move to that model because they always struggled with, well, am I just prioritizing? Because for most of the doctors, they felt, well, I just want to get on and solve it and move to the next call. And so that impacts some of the clinical indicators around your time for triage, some of those measures that the neighbourhood healthcare homes model utilises. You know, really shifted, because once you move to a management space, you're not going to be meeting the kind of 3-minute usual triage call measure. So and I think continuing on from that, after COVID finished, was some of the clinicians were in a quandary. Do I continue to manage, or do I drop back to the triage space? And so it was really good, though, to have the push through to the virtual consultation and encourage really the patients to accept that they were still getting good care, because I think there are a lot of perceptions about, well, I don't really receive as good a care when I'm not in front of the clinician, as opposed to them managing via a Zoom or a kind of virtual space or a telehealth. There was still that perception that the best care is actually in front of the clinician, and vice versa, the clinicians having some feeling that they enjoy that patient interaction. So having had the big shift from COVID into that space, and as I spoke to in Taupo at the conference, it was really hard to maintain that once we came out of the COVID space. It was almost like quite a default back to the in-person consultation, even though we tried to maintain virtual consultation slots in the clinician schedules to sort of almost force that space and keep people there. But we did have quite a default, and so that was quite a challenge. So neighbourhood healthcare homes and its systems, although we've evolved them for our practice, I think did assist us. Had we not already been on that journey, we would really have struggled to take the quantum leap to the telehealth space. So I was very grateful for that. We were kind of already in a position where we were able to transition. We still had to continue to evolve our systems and our processes, but that was more around logistics in the practice rather than the telehealth management itself. It was more, if they did need to come, then how would we manage it logistically with entry to the clinic, red zone, green zone, etc. So from there, yeah, I guess it was a good training run for the revisit today. And so I'm sure there were many managers or clinicians who were hot on the email and phones last night, gearing up your practices or organisations for today. And that was certainly the space I was in last night, really gearing us up for what would that look like with the doors being shut today, that the phones being the primary method of communication, getting out bulk texts, and I'm sure whatever mechanism you use, Vensa, MedTech or otherwise, there was bulk texting going out to patients last night explaining what the impact of the move to alert level 4 lockdown means in a primary care space, and also communicating with the hospital around our after hours service provision in order to create systems to protect GPs, that we would be operating a telehealth model from both our practice and when we do after hours service inside the hospital premises, as we use their rooms and A&M in the evening for after hours. So re-establishing those processes, we were quite fortunate. We have a very large, probably 70% of our GP workforce is from the US particularly. Some of those doctors have already been working in a COVID environment and had actually had close family members who had actually caught the illness, and so they were quite primed for working in that environment and very quickly shifted to a telehealth space. We still had our guidelines that were developed from last year, but there was a lot more confidence, I think, this year for clinicians having already spent quite a lot of time previously in the lockdown model. So it was a really good transition back into it, I believe. And I guess, like all of us, we're waiting with bated breath to see how long is this going to last. But yeah, I think this is a climate that we're just going to have to keep adjusting to constantly. And I think we all evolve and grow this space and learn from our experiences, what worked, what didn't, and how we can continue to tweak it, and so forth. I guess one of the main things that I think about in this space is also to generally our GP workforce. So beyond kind of the neighbourhood healthcare homes model and specific telehealth experiences, is also this notion that we are really struggling with GP workforce and GP workforce provision. And I think the virtual space is really going to be important going into the future around workforce. The reality is, you know, if I recruit someone from somewhere else, we're just pinching from Peter to pay Paul. That actually we have to buy in other modes of assistance. And we know that there are various virtual companies out there who offer services. Our Kaitaia Hospital currently contracts emergency consults who presented at the TOEFL conference for what used to be the overnight GP service after hours, which is 10 p.m. to 8 a.m. in the morning. So looking at those types of services for expansion into casual patient demand, particularly if you're in a holiday area and we have those large influxes. Also too for locum top-up. It's just as hard to get kind of locum top-up as it is to have a long-term workforce. So, you know, what companies with good systems offer those virtual workforce that we can look to tap into, because I think that is going to be part of, not the complete, but part of a workforce solution into the future, which I'm very keen to purchase because we really struggle. It's very much our Achilles heel, as I'm sure it's everywhere, to continue to be able to offer provision of care. And I guess that's often met with resistance. There is still, again, the notion that in person is the best form of care. But I think to have any care, we have to think outside the box into the future around what are the safe and good systems, good clinical governance around virtual workforce that can be accessed elsewhere, whether it's elsewhere in New Zealand or elsewhere overseas, but looking to that as some form of solution towards our workforce problems. So our learnings from today were that, I think, you know, we transitioned really well. The day went well. And it was just re-establishing the red and green zones, tweaking all of the schedules, working out who was here, who was not, and just, you know, riding the space. So, kia ora everyone. Thank you very much.
Kia ora, Cheryl. Thank you. That was a really candid and true reflection of what you've been through over the last 18 months. And I think many practices can probably relate to that, and particularly in terms of the struggles around workforce and having to look at different options and wider options around virtual care to cater for your population. So, kia ora. Okay, Angela, I'm going to get you to have a chat to us about your experiences. I'm really interested to hear how, in terms of both your clinicians and patients, how agile they were today and how confident and comfortable they were going back to telehealth, and all the rest of the gems you've been working on, the more slow burn projects around telehealth. So over to you.
Kia ora koutou. So today was actually, I think, like Cheryl said, I was surprisingly smooth. I think last time when we went into lockdown, so I'll start with we're a virtually integrated service. So we have a small rural hospital and a general practice. Rural hospital CDHB, and the general practice is privately owned, and we work together as one team without the structures. With structures, clinical and governance, but without the same employers. And our patient population is 4,000, and 24% of that are over 65 years. We have been using telehealth for quite a long time because we have a population of patients who live substantially far away from the clinic over the mountains, and so we have used it particularly for them with the young children and older family members to provide support before they made the decision about flying out or staying at where they were. So we had been using Skype for that, and then over time, and with the benefit of lockdown last time, we moved to DoxyMe, and we identified a champion, and she has been the person who's helped all the clinicians with use of DoxyMe. That includes not just our GPs, but our nurses and also our mental health team. So they are all set up on DoxyMe, and this morning, within an hour, she had everybody checked back in and going again. I would agree with Cheryl that post-COVID lockdown last time, whilst we continued to maintain space for virtual consultations, patients' preference seemed to be, and they were offered virtual, patients' preference was to be face-to-face. However, they have very quickly adapted today, and we were amazed at how little, if any, actually, feedback of a negative kind came from any of the patients. They were all just happy that they were going to be seen and that they would get the care that they needed on that day. We had quite a lot of patients ring and cancel because what they had wasn't, from their point of view, urgent. So that gave the clinicians a bit of space to do other things, but we also provide urgent care. So we had to get ourselves all set up so that patients who needed to be seen could be seen in a safe way. So yeah, so I think it was really important for us that we had a champion, and that person made themselves available this morning to all the clinicians to make sure that everybody was up to speed and going well. So that has, they're all roaring through it. So it's been quite amazing. But yeah, so I hope that from now we'll continue to offer more of that. But one of the things I suppose that I would like to talk about is some of the stuff that we do with the Canterbury DHB teams, the specialist teams. So Kaikoura is 2.5 hours from Christchurch. So we are often dealing with quite major emergencies, and we have a video cart that we have used for contact with either ICU or ED when we're dealing with a patient who is in seriously acutely unwell, and that support provides our team support until the retrieval team arrives. And it's great because with the video cart, the specialists in Christchurch can actually see all the monitors as well as the patient. It's really high quality camera, so it's fantastic. But we also use telehealth in different ways to protect our patients from the 2.5 to 3 hour journey each way to Christchurch for what can often be just a 15-minute appointment. And if you know anything about Christchurch Hospital, parking is not that easy to find, and for our elderly in particular, it's really difficult. So in partnership with the rheumatology team, Professor Lisa Stamp and her team, we have a virtual rheumatology clinic that happens once every, I think it's every 6 weeks now, 6 to 8 weeks. And Lisa and her team come once every 6 months. And so that team see their patients over video link with one of our CDHB nursing staff present. And that nursing staff member went to Christchurch and was trained with the team for over, I think it was nearly 2 weeks. She spent doing joint examinations and learning how to do them so that when she's with the patient, she can do exactly what Professor Stamp wants or what the CNS for rheumatology wants to know about the joints. And so patients don't have to travel for 3 hours. Professor Stamp doesn't have to travel for 3 hours and then return for 3 hours. So it just means that they can see more patients, which is fantastic. Patient feedback is that it's really a great service. And Emma, who's the rheumatology nurse here, I was hoping that she'd be here tonight, but unfortunately before COVID lockdown, she became unwell, so she isn't here. we also have used it quite a lot with palliative care for specialist teams involved in the care of patients. So I can think of one example where I set up a Teams event with a palliative patient who was in our acute ward, and with her family, our district nurse, our GP, and her the nurse on the ward. And so everybody was in the same room with the palliative care consultant and their team, and everybody got the same messages at the same time. And I think for the patient involved, her children found it really valuable, because they would not have been able to go to that meeting if it had happened in Christchurch, because they would have had to take a whole day off work, which, you know, they were saving their days so that they could take time when their mum needed them the most. So so those kind of things, I think, are things that we need to explore more. And I see that there was a question about funding. So for the rheumatology nurse, she works for the DHB, and it's a DHB service. For the practice, when we have, so at the moment we've got several patients who are working with haematology, and the haematology team like a nurse or doctor to be present. At the moment we use enhanced capitation funding for our support of that, but I think in the long term that's something that needs to be investigated, is how that's funded. It certainly provides huge advantages to the patient, because their team locally are fully informed and involved in the consult. B, they have someone that they can talk to after the consult, because often, you know, patients go into a consult, they hear all this information that's like noise and they don't get it all. And afterwards they get time to breathe, and they're with somebody they know and they trust and they've been working with for a long time, and they can sit down and go, well, what did that mean? What does that mean for me? And get the answer from the clinician who's listened to what the specialist has said. So I think it's patient-centered care at its best, putting the patient first and putting the patient in the middle. And yeah, we really value that ability, and we'd really like to extend it into other services. So that's really pretty much what I had to say. I hope that you're all doing really well in this space. I think I have to say, I felt shocked last night that we were going into lockdown that night, and we had that night before we had to start everything, and we had to be ready for overnight, because we obviously have staff on duty all night and all day, and we had to be ready for overnight, and then had to be ready for the next day. So I felt quite shocked at the time, and I think, but you know, thankfully, having been there before, it was much easier. We had all the systems, and we had all the lists, and it was just a matter of working our way through it. But it certainly was a big shock, and I hope that everybody else is coping really well, and that nobody's eating far too much chocolate, because we did eat too much last night. Kia ora.
Kia ora, Angela. Yeah, I mean, I just have full admiration for what you've had to go through over the last 24 hours. And you probably the sleepless nights that you had, or sleepless night last night that you had in preparation for today. So well done. Once again, primary care rises to the occasion. So, okay, I'm going to pass it over to Carol, who's going to give us some really interesting insight into some of the project work she's been doing within her DHB. Over to you, Carol. Thank you,
Kia ora koutou. Thanks for the opportunity to have a chat with you. Look, I've got a probably slightly different background. So I've got quite a lot of health background clinically, but a lot of it's in acute hospitals and DHBs, certainly here, and I lead a lot of service improvement initiatives. So this was, I'll tell you how far we've got in the end, but this was born out of probably two ideas, really. One was from probably about 12 or 13 years ago back in the UK. We had an idea to try and get GPs to almost enable them to be able to find a specialist, almost like you would on Skype. So if they've got a patient in front of them, go, I need a gynecology opinion or a urology opinion, who's available? And we wanted to try and set that up. And I actually left the UK before that got up and running, but it has since got up and been quite successful. And there are some links that I've given to Jess afterwards if you're interested. And then with the last lockdown, I had the dubious task of setting up the MIQs with about 6 hours notice of flights coming in. So I kind of legged it in Christchurch out to the airport and set out the MIQs and didn't come back for several days and several weeks really. And one of the things I set up very quickly there was a virtual ward, because I was quite keen, like very similar to actually what Angela's saying about, you know, you're really quite mindful when you're transporting patients either a long distance or when you've got really difficult decisions to make, which is taking somebody out of MIQ into hospital, making the right decision. So I actually very quickly set up a virtual ward where we set up a primary care organisation. Almost we treated our MIQs like an ARC. And we set up a GP organisation, and then we had I had public health, and I had a respiratory physician, and I had ED and Gen Med consultant all on this virtual ward, and we actually ran through all the patients. And as some of you have said earlier, I mean, telehealth's been going for some time, but it's needed a bit of a boost from something like COVID for people to actually just get very used to just using the technology that we've got in front of us without making it overly difficult. So what I tried to do, what I've been trying to do in Christchurch was kind of keep with that momentum and go, well, if we were able to do that during COVID, why can't we do this out of COVID? So what you're looking at here, I'll just quickly walk you through, was basically a flowchart that we've tried to do for 3 specialties. So we applied for some of the sustainability funding to actually look at supporting 3 specialties. One was CAF, one was respiratory, and one was cardiology. And that was purely because we'd got specialists who'd got an interest and wanted to do more in this virtual space. So the idea for us was that we wanted to offer GPs a structured 15-minute appointment between the GP and the consultant. We actually, we are not looking at having the patient involved. So it's not a patient GP consultation. This is purely an opportunity for the GP to talk to a specialist about a specific patient, not hand them over, not refer them over, but do the same as you would if you were trying to ring them, but without all of that playing, you know, telephone ping pong around there in theatre and you're then busy with a patient. So the idea was the GP would see the patient and would basically want to see them, would actually want a conversation with the specialist, which would either prevent a same-day admission or just a general referral. Or although we've got the kind of request for advice, it's always one way, and we wanted a way of having a 2-way conversation. So the idea was you'd sit with the patient, you'd say, actually, I'd like to speak to the specialist about your condition and the treatment plan. And you would go on Health Pathways, and then you would look at booking a session. So in the same way you'd book a hair appointment or anything else, you'd be able to see some of that consultant slots. And we tried to do them in 15-minute intervals, so they kind of mirrored what a normal GP appointment might look like. So it might be Wednesday afternoon, 2 o'clock, 2:15, 2:45, and then a 15-minute break. You would fire over a little bit of the information just so that the consultant had got a chance beforehand to pull up the clinical notes. And basically then the booking system would schedule that appointment. So both the secondary care clinician and the GP in their PMS would then have that appointment. And then of course at 2:15 on the Wednesday or whatever, they'd both hook up and they'd have a conversation about the patient. We decided we were going to fund this at a flat rate of $50, including GST, for that 15 minutes for the trial, because we decided that we didn't want GPs, we wanted GPs to engage with this. There were some views that said, well, this is part of GP normal business. If you weren't doing this, you would be sending a referral or phoning the consultant. But there is also an argument that you're preventing a hospital appointment or the hospital time, and this could have been a patient that you could have seen in that 15-minute slot, so it's lost revenue. So we thought, well, that seems a reasonable way to do it. And then basically that virtual advice session would take place between the GP and the hospital. It is not actually the hospital's responsibility to then document that. If you want to just flick to the next slide, Jess. We decided that it wasn't actually a job of the hospital to document that, but we have got the ability to do that in Health Connect South at the same time. So we thought, well, it'd be stupid not to do. But essentially the transfer of the patient does not move from the GP. The GP is still managing the patient. All they're basically doing is getting some advice. So we did have a discussion about whether the patients would join the discussion. We said that would be by exception. And if we did have a patient discussion as well, we would need to at least double that time. We didn't think 15 minutes with a GP and a patient and a specialist having a conversation about a treatment plan was really going to cut it. So that was the plan. Issue we've run into is the technology, to be really blunt. We'd got the opportunity to be able to go out to market and just get something, but we were really keen that this needed to integrate with our existing systems. Otherwise, we might prove the concept, but it wasn't doable. So to be really blunt, we still haven't kicked this off. We got everything ready to be able to do all of this. We've gone through all of the health pathway, the tech that we might need, just additional screens and things like that. For example, we got the funding all sorted out. The CAF consultant is doing a bit of virtual stuff, but really just doing the typical. She's booking out, say, between 1 and 3 o'clock on a Wednesday afternoon, so that GPs can call during that time, which is okay, but it wasn't really what we were trying to do. So to be really blunt, we've not got this off the ground, and I'd love to say it's been a great success and this is how it's worked and this is what's happened, but it hasn't. But I'm a great believer in kind of just sharing stuff even that hasn't worked or that's work in progress, rather than necessarily wait until it's all finished and go, hey, look, we did this. So that was a plan. So yeah, if anybody else has managed to crack some of that, particularly around the tech, I would love to have a discussion with you and understand how you've done it with your IS departments. But as I say, we've struggled with this, so this is still at plan stage and not delivery stage. So that's it. Kiora, thank you.
Kia ora, Carol, thank you. And yeah, hopefully someone potentially on this webinar will connect and you can share learnings and challenges to move forward. So thank you. Our next panelist is Dr. Janine Bycroft. So wearing her 2 hats today as a GP and also the clinical director for Health Navigator New Zealand. So I'll pass it on to you, Janine.
Cool. Thanks, Jess. Well, look, this challenging times for everybody, and look, tap my hats off to everyone who's just pulling out all things to make this happen and the huge changes that happened today. What I was just going to cover was, just change the slides for us, Jess. Thank you. We do have a number of resources on the Health Navigator website to help you with telehealth. So obviously I work as a GP, and we do have a number of videos that you might find really useful. So there's one there that just gives a really sort of a easy, simple checklist of things you can go through with your whānau about how to use telehealth. And then the second one, the one on the right, is one we've just made recently around how to use patient portals. So this might be a really good one that you might want to share on your websites or through your social media if you've got Facebook or other means. And it just really goes through and shows people how to sign up for the portal, how to view their results, how to send secure messages, etc. So we just, it goes through all those key things which you might find really helpful. So that was being done with Health Literacy New Zealand. So it's really been designed to be easy to understand and useful for all your whānau and patients. In terms of experience with telehealth, I've become a real advocate for it. It is a big change, and like most of you have described, after COVID, we all slipped back into seeing patients in person. Just one thing to notice that the National Telehealth Forum does encourage us to say in person for consultations, and because face-to-face can be confusing, video consults can be considered face-to-face. So that's just a plug to encourage you to use the words in person for in-person consults, and because face-to-face can be confusing. One of the things I thought it might be worth just also pointing out is the big value of video consults over telephone consults. So observation from looking at lots of colleagues, and that is that everyone just switched to the telephone because it was easy. We've done it for years. We've picked up telephones. It's just so much easier. But all the research does show you lose a lot more with just a telephone consult compared to a video consult. So yes, I know it's harder. I've had a few frustrating video consults when we can't get the tech working, but it is worth the effort if you can have a way to try and support your whānau to get those video connections working. You can see more, you can see what's happening, you can see how sick a kitty looks. You can get, as part of Healthcare Home, and I also work at ProCare, a number of PHOs, we've been developing modules around telehealth, and there is actually a lot more you can do in terms of physical examination or getting people to give feedback to really understand how sick someone is or isn't. So there are some fantastic modules out there around how you can even do musculoskeletal examinations and respiratory examinations using video, which you just can't do with telephone. So look, we'll make those resources available with links. I'm sure Jess will get those out to you. There's some really great information in there. And the respiratory one I want to update because I was at the GP College conference a week ago and was really grateful to hear Professor Dee Mangan speak. She's originally from Canterbury and she now is in Canada, for any of the others on the call that heard her. And she's been involved with managing large volumes of COVID positive patients in the community through primary care. So there were some really fantastic learnings from their experience. A couple of them I thought I would make is, firstly, they found very few patients actually needed to be seen in person. They could do a lot of it by telephone or video consults to actually monitor people. They set up virtual wards, and every day they would ring anyone who was COVID positive until they got through to day 14. And they also streamed patients into high risk, medium and low risk. So the patients who were deemed to be at high risk, they also actually gave them a pulse oximeter. So this is something that hasn't really taken off yet in New Zealand, but it is an incredibly useful form of telemonitoring that we could be starting to adopt and incorporate into our pathways. So you'll see Dee is working with the Ministry of Health and the PHO Clinical Leads Group to look at how we can adopt some of those things that they've done. And but that's just a heads up. Pulse oximeters was one of the things that made a big difference. What they did is they, for those higher risk patients, they got them to take their respiratory rate, their pulse rate, their temperature, if they had a thermometer, and the pulse oximeter, and to record that. I think it was twice a day. And then if they saw the trend was going down, that was a really important indicator that that person might be decompensating. Again, I think she said it was that sort of day 7 to 10 when people often could deteriorate, and they had some really amazing examples where they'd phoned someone on the Saturday, a young person, wasn't expected to be at high risk, but his he was feeling really tired, but because they had those phone calls, they picked up that he was actually starting to decompensate, sent him to hospital, and he got admitted straight to ICU. So he would have previously been missed for the whole weekend and could have ended up in a much worse state. She's also given a link to the website where there's some fantastic resources that can be used, and a few of us will do some work to try and adapt them for New Zealand. If anyone wants to be part of that work, let me know, and Jess and others, I'm sure we'll rope in a few who might want to be involved. They had a little handout about for families about how to use a pulse oximeter. They have a video and they have their whole clinical guidelines. So again, that PHO clinical leads are looking at how those guidelines, what bits might be pulled into our health pathways. So again, watch this space. But in the meantime, there is some really valuable resources there around what the high-risk signs are, of course. So it's if there's any comorbidities, if the age is over 65, etc. So they'll see patients with anyone whose symptoms are deteriorating immediately becomes red and was given an oximeter. Any age, if they've got medical comorbidities, age over 60, and they would be monitored every day for 14 days virtually. And out of about 650 patients, they only saw about a handful in person. They were able to manage everybody else using telehealth. So that was one of the key things I got from that. In terms of advantages of telehealth, for me, Well, for our practice, we've had times when staff have had mild urti symptoms, so they've had a mild cough or cold. They've been able to carry on supporting the practice by doing telehealth from home. So that's obviously really valuable from a workforce perspective. It's so challenging if any time someone's got a slight sore throat, cough, runny nose, they're off work, and you're suddenly just that many short 3 or 4 people at a time. That's makes it incredibly difficult. If they can carry on doing work from home using telehealth, that makes a huge difference. If you're not yet moved your PMS into the cloud, you need to do so as soon as you can, because that made a huge difference for us as well as a team to have that flexibility. We couldn't have done that before we'd moved to the cloud, which fortunately we did about 3 weeks before the first lockdown. So that was very fortunate for us. It's obviously also very convenient for whānau, as we've heard, saving huge amounts of time and effort. And I've also found for a lot of the mental health consults, actually telehealth has worked really well. It's much more convenient. People haven't had to come into the clinic, and seeing people in their home environment is also really valuable. You can pick up lots of clues, and it can sometimes be a great way for conversation starters. You might see something on the wall or a poster or pictures or just anything that can be valuable from that perspective. And it can be a little faster, because you're not having to go out to the waiting room and bring someone in and all those sorts of things. And I observed how for myself, and probably for a lot of us, when someone's come and seen me in person, I'll sometimes listen to their chest or take a blood pressure or do something that I probably really didn't need to do, but you feel like you've done something extra for them, seeing them in person. So part of that is educating people that we can do a lot of that now virtually. Obviously, there can be times when the tech doesn't work, and you might sometimes have to convert telehealth consults into in-person. But yes, that is part of the ups and downs with it. So look, I'll pause there so that we can look at some of the questions.
Yes, I've got a few here, and I think, Janine, these probably applicable to you. In terms of telehealth work for disabled patients, including deaf families with children or who have ASD, FALS and behavioural challenges, have you had any experience with that and any recommendations?
Yeah, actually, sometimes it's worked really well, because it can be quite awkward when you've got the children in the room as well as the parents. And so if they're able to do a telehealth consult, the child can be playing happily in their own environment, and they're not running around and pulling everything off your desk and causing havoc, which we've all experienced at different times. And also they're not in earshot of hearing some of that conversation, which sometimes is better for them not to hear when you might be talking about some of the issues for the family. So it can work well. For people who are deaf, that can be more challenging, but you can access signers, so that might be something that can work. Haven't had much experience of using it for clients who are deaf yet. If anybody else has, yeah.
And the next question, is there an ideal split between face-to-face and then alternatives to in-person consults? Has there been given a guide this time? I know last lockdown we were given a percentage to kind of work towards. Is there anything out there at the moment, or we're working back to those guidelines?
Yeah, I think the general guide at the moment is, as before, aim to have 80% as telehealth consults. And in actual fact, because the Delta COVID is that much more virulent and contagious, we should be aiming to keep as many people out of the practice as absolutely possible. I'm going to be trying to see people in the car or outside as much as I can. I was doing Reds yesterday afternoon, and I just think of all the things I did wrong and need to really tighten up on, because although I was in full PPE, there were little things afterwards I thought, oh, if this Delta virus is that much more virulent, we just have to be so much more strict than we were last time. The other thing on the PHO clinical leads call before is that there is that need where possible to split teams into a red team and a green team. So that's something we didn't do previously to the same extent across most practices. We had red patients and red streams, but we didn't have kept them separate. So actually keeping the teams of your practice staff separate. So that's a big change and logistically quite challenging for us all. In a big practice, it might be possible to have 2 teams sort of with separate toilets and staff rooms and those sorts of things, but most of us in smaller practices are just not going to be able to do that very easily. We certainly have 2 cabins on our back lawn at the moment. I'm sure others will be, well, sorry, 1 cabin at the moment, and we're talking about a second. I'm sure others will be doing those sort of logistical things to try and facilitate that.
That's a good point, Janine. Yeah, lots to think about. Okay, there's just a comment there about Health Navigator has been an excellent tool for nurses doing phone triage, especially for parents to use. So that's a little plug there. And maybe a question for you, Cheryl or Angela. How are you finding young people responding to telehealth consults?
I can say that the feedback that I've had from our clinical team is that young people find it really easy and they like it a lot. And yeah, so they embrace it here.
Yeah, I was just going to add, often I've heard it's almost like the virtual or telehealth is almost like a poor relation to an in-person, and it's just not at all for a lot of people. I mean, I have a discussion with a lot of colleagues, and I've done a lot of virtual stuff now with my GP, and I would pay double to have a virtual consultation than I would go in face to face and have an in-person one, because it works better for me. I can judge it with timing. I don't have to travel. And I think we've just got to remember that although for a group of people, they might prefer to go in and see someone in person, there's a big group of us that actually we're very happy with a virtual consultation, and we should stop this thing about it's a poor relation to a face-to-face. It's not.
I think too that young people live in quite a virtual world, and so for them it's quite easy to adapt. It's been easy to adapt. I would say that one of our GPs says that that virtual is fantastic for everybody, but she finds that for our elderly who live alone, where her touch might be the only touch they have in a month or whatever, that is an important part of the consult. That might be just taking their BP or or listening to their chest, but that's just gives them that human contact that actually is an important part of the ways of well-being. But yeah, I agree, virtual is great.
Yeah, there's a balance. I was just going to jump in, Janine, that the thing you were saying about respiratory, I would really back that. From running MIQs for about 5 months, we started running through how do we decide who we transfer, who's deteriorating, who's not. We sent out pulse oximeters, so we got the nurses in the rooms doing pulse oximetry and doing obs. But actually the biggest decision making around respiratory symptoms and where they're getting worse were all about what we were seeing when we spoke to the patient. And, were they cynos? How were they sitting? How were they breathing? But there were some key questions that we asked him, and our respiratory clinician came up with 5 or 6 key questions. And it was those questions that made us decide whether we're sending people to hospital, not the set of obs. In 80% of the cases of patients that we transferred out of MIQs, it was based on the questions and not the observations, which was really interesting. So it put a completely different slant on what we thought we needed to do versus what we actually did.
Yeah, that's right. And Dee said you didn't need to listen to their chest.
Nope.
Which is what we always think you have to do. Obviously, if you think they might have asthma, then that's a different scenario. There's a question there about whether health coaches can be used and HIPs could be using telehealth. Absolutely. I think it's a huge opportunity. They don't need to be in the same room. I'm a clinical lead for Here Toitu, which has health navigators or health coaches. They've been using telehealth all the way through last year because and it actually increased opportunity for connecting with people. So you just got to get them set up, and ideally it's nice to meet someone in person for the first time if you can, but if you can't, then it still keeps that access and opportunity there.
Great, thanks Janine. So we've probably got time for one more question, and Cheryl, I thought if you could answer this. So we've got one around equity. And it obviously continues to be a slight unknown with telehealth, but from your perspective and your patients and community, what have you seen around telehealth from primary care? Is it being equitable? Are most, priority populations taking it up? and the engagement? Is that there with whānau?
Yeah, I guess the equity question is a real hard one to answer everywhere, because unless you're really focusing in on, am I addressing this part of my of the population of the practice? What am I doing to enhance the service that we provide? And I guess quite often we're so busy in practices, we are ensuring that we are providing the service to everyone. So I think if we think about some of the equity barriers, they are around access and around transport, and so in terms of the those particular aspects that present barriers to equity, then you know, it does, whether it's telehealth or a virtual consult, it does actually reduce that barrier for transport. You know, that the person can stay home and can stay home safely. Again, it's dependent on their you know, their stability around either a cell phone coverage or internet. But you know, it does reduce that barrier for transport, which is a huge barrier in the far north. You can't dial up a taxi or an Uber or catch a bus or any of those things. You are, you know, often whānau are dependent on whānau to get to appointments, or you know, have they got enough petrol money to come to town? You know, some folks are 15 minutes to Ahipara, others are an hour and a half to the Cape. So it just depends. So I think there are aspects of you know, reducing barriers to accessing health and dealing with equity that telehealth does actually address. Transport being the main one. Also access. Today, you know, we were already fully booked a week in advance, and today the clinicians via, you know, telehealth were working through their schedules as if they were seeing the patients, but phoning each one that was already booked to see if there was a possibility of managing it via phone or making other arrangements. And they were able to move through that quite rapidly. But also I was having a lunchtime conversation with one of our docs who said she was actually able to provide better care to one of our Down syndrome patients because she actually had the time. And as Janine referred to, you know, there was less kind of, you know, distraction going on in the room due to behaviour and other things, where she could actually spend 40 minutes, because she had already moved through a lot of the calls, spend some good time actually unraveling, getting a better history rather than just that forced acute problem. And I think we have a population where they're quite stoic and they rock up for acute situations, like they should have come 3 to 4 weeks prior, and so they present very acutely, and the acute situation is always the priority, as opposed to what we're ideally shooting for in terms of primary care, which is that, you know, getting a good history, understanding what's going on for the whānau, and making some good decisions, and perhaps dealing with some of the gaps that we could improve on to be more proactive in terms of health. And again, that is better access, because time is almost given back to the clinicians to be able to do a better job. And not to say that anyone's doing a bad job, but it's more that, again, access. It does create space and capacity for better access. And I think that goes towards improving equity, because if whānau get you know, an improved service that deals more proactively, then maybe we can start to work on some of those things that just drive the acuteness and understand what's causing the shortness of breath, rather than just jump to conclusions around, is it just respiratory because whatever is out there? Well, no, there's a whole lot going on with that person that we need to unpackage. So is it the magic solution? No, I think it's part of a solution, though, that does address some of the barriers to moving towards equity.
Thanks, Cheryl. Great answer. And last question, I said the other one was last, but one more. Have you any examples to any of the panellists around NGOs using telehealth to hook into general practice with a person or family in their home? Has anyone got any examples of that?
Yeah, prior to this space, I mean, we regularly, because Te Huku Hauora has a range of, as a Māori health provider, we have a range of services, including mobile nursing, health promotion, pharmacy, dental, etc. And so, yes, we often work alongside our mobile nursing team who are going into the community, into homes, and have the ability to do much more of a whānau order assessment, and then link back into, you know, a book GP appointment so that they can, from a clinician's perspective, feed back into the GP, but it is that face-to-face via, you know, whatever the virtual medium is. So most definitely, because we are an NGO, we utilise that quite regularly, particularly with our mobile nursing team. And it just enhances, particularly some of those challenging patients, your diabetics, your male patients who don't necessarily want to come in to appointments, that, you know, all of our diabetic annual reviews and our chronic folk that we're trying to chase, utilising our mobile workforce to actually access them and then link them back into primary care.
Great, thanks, Cheryl. Okay, so I think that was all the questions. So yeah, just to confirm, this Health Navigator have got some great patient resources. The one on the left there is about a checklist for patients to go through getting ready for a telehealth consult. And then the one on the right is around preparing and stepping through patients accessing the patient portal. So yeah, highly recommend those two resources. And then I just wanted to, if it moves to the next slide, onto the Healthcare Home website as well. So here, within our model of care, you can tap into each one of the characteristics. So click into them and it will bring up all resources around telehealth. So there, patient engagement or alternatives to in-person consults. So tap into any one of those and there's a whole suite of resources mainly focused around providers, but also please feel free to get in touch with us. My contact details are there. If you need any support around implementing telehealth in your practice, happy to help. Worked in general practice myself before. So if we can help in some way, or there's some resource that you need that you can't find on a website, please reach out. We're here to help. So, okay, so we're going to finish now with karakia. Before I do that, I just would like to take the opportunity to thank the panellists tonight. So Cheryl, Angela, Janine and Carol, thank you so much. I know you've had a big and a really long day today, and I think that's probably going to be you for the rest of the week. So good luck and thank you for sharing your wisdom and your inspiration to keep going in the telehealth space. So it'll be great to have one maybe in a month or two just to recap some of this and see how we're going post this lockdown with embedding telehealth and making sure we've still got it front and centre, as we never know that we could go into multiple lockdowns going forward. So we really need to be prepared, have all our processes and systems tight so we can pull them back up when we need to. Okay, so feel free to join me in the closing karakia. Ki hore te marino, ki whakapapa pounamu te moana, ki tere te kauhorihoi, I mua I tau huarahi. Kia ora everyone, go well tonight. Stay well, stay safe.
Thank you.
Ka kite anō.
Ka kite.
See ya.
See ya.